Hi, everyone. We are going to talk today about high-risk labor and birth. So, to get started, these are all different topics that we think about when it comes to high risk. So these are the main ones we're going to talk about today. Preterm labor. So preterm labor and preterm birth. If we remember what term is above 37 weeks. So anything that happens before 37 weeks is preterm. Okay, as long as they're over 20 weeks, because remember that 20 weeks and earlier is considered a spontaneous abortion or indicated or whatever. So we break these babies down into other categories where we say that under 37 is preterm. But remember, we said previously that for patients that have high risk conditions like preeclampsia, sometimes we use a cutoff of 34 weeks. 34 weeks is what we consider late preterm. From 34 weeks to 36 weeks and 6 days, these babies typically do better than babies that are earlier. So the earlier the baby, the more problems we could have because the organ systems aren't as developed and things like that. Okay. One of the things we consider is if they're low birth weight, so if they're less than 2,500 grams. Also, we'll talk about growth restriction. And so we've mentioned this a couple of times. I've mentioned intrauterine growth restriction in relation to smoking. We also see intrauterine growth restriction in relation to preeclampsia. Anything that is causing like a chronic vasoconstriction or impairing blood flow over time is going to affect the way we grow our babies. So that's what IUGR is. All right. So preterm labor, if a woman goes into preterm labor on her own, then there's a lot of different factors that could be causing it. Oftentimes it's related to an infection. Okay. Sometimes it could be a structural issue. If she has like a bicoordinate uterus, or sometimes if there's fibroids in the uterus, things like that can contribute to it. It's something that causes, if anything, that's causing a decrease in progesterone, because remember, progesterone is maintaining the pregnancy. All these things are considerations. So when we're predicting and trying to prevent preterm birth, we can look at a few factors. In preventing preterm birth, we're going to be thinking a lot about our preconception counseling, our things that from the very beginning that we were concerned about. Because remember, things like uncontrolled diabetes or poorly controlled diabetes could increase the risk of things like spontaneous abortion and preterm labor and birth and things like that. So getting correctable risk factors under control from the start is going to be important. If she has a history of having preterm birth before, we might say, you know what, let's give her prophylactic progesterone. So in the previous week, we had talked about a cervix that's shortening and how they can put that cerclage in there to try to cinch it closed. If we have a patient, though, that has had preterm birth before, then even before the cervix starts to shorten, they might start her on progesterone in order to try to maintain her pregnancy. So that's some of the things we can do for preventing. We're not automatically putting in cerclages to everybody. We're not automatically giving progesterone to anybody. These are going to be for women who have had a history of this happening before, which increases their risk of it happening again. So in addition to risk factors, one thing that we can do, like if I have somebody that comes in with signs of preterm labor, we can do what's called a fetal fibronectin test. This is where they take a swab back by the cervix and they look for fetal fibronectin. And fetal fibronectin is a glycoprotein that it can show up in the presence of labor. So if we do the test and it's negative, that is very reassuring that she's not going to deliver in the next 2 weeks. a lot of things can cause a false positive. So a positive test doesn't really tell us much, but a negative test is very helpful. And the other thing we can do is look at that cervix to see if it's getting thinner. So a cervix that is nice and thick, like 3 centimeters, is probably not laboring prematurely. But if it starts to shorten, then we're worried. Okay. So signs and symptoms of preterm labor. Signs and symptoms of preterm labor are a little more vague. So when we think about, we have discussed before, is it labor? And we talked about, well, if the cervix is changing, and that still matters for this. But in preterm labor, they feel maybe pressure in their pelvis. They might have a dull backache. They can feel tightening, but they're not sure. Is that the baby moving? Is it contraction? I'm not sure what I'm feeling. And these can all be signs of labor. I've had women come in with these vague kind of symptoms because anybody who's had a baby before will tell you that they felt pelvic pressure and a dull backache. Okay. But then we check their cervix and actually they're 5 centimeters. We're like, oh, you're actually in labor. That's unfortunate, if they're early. But so sometimes these symptoms are very vague and we're not clear. So we're still going to rely on cervical change as our true tell for if she's in labor. But before, I'm not going to sit around and wait. If she's 32 weeks and she's got pelvic pain, a dull backache, and uterine tightening, and I put her on the monitor and I'm seeing that she's having contractions, I'm not going to sit around and wait for hours to see if her cervix changes. We're going to start being more proactive. Okay. So I don't want her to deliver at 32 weeks. So what can I do? Things we'll think about for this. Remember that one of the main causes of preterm labor is infection. So giving her an antibiotic is a good idea. Plus, I don't know what her group B strep status is if she's preterm. We haven't checked that yet. So that's another reason to give an antibiotic. So we'll get them started on antibiotics. And we want to suppress the uterine activity. So these are our tocolytics to try to slow contractions down. All right, and so that's what this is on the slide. It's not my time. Indomethacin is something that we have to be careful with because that it causes a premature closure of the ductus arteriosus for the baby if they are giving it in a certain time window. So usually our first choice is nifedipine. Nifedipine we talked about in relation to preeclampsia, and if you remember, we were giving nifedipine for blood pressure. And that's what nifedipine's job initially was designed to do, is to be a blood pressure medication because it's a calcium channel blocker. But it works to help relax the uterus as well. So nifedipine is a choice for preterm labor. Terbutaline is a choice for preterm labor. And terbutaline we talked about as the tocolytic we would choose if we were having prolonged decelerations. When we talked about abnormal fetal heart tone patterns, terbutaline was something we considered. And if you remember, terbutaline causes tachycardia. And so if I'm giving terbutaline, then I want to get a good assessment of vital signs. Okay. The other thing that can happen or that we can consider is magnesium sulfate. So let's talk about this for a minute. Magnesium sulfate has tocolytic properties. And so for our patient that if she's on magnesium sulfate for preeclampsia, it's sometimes harder to get her into labor. And in the postpartum period, your patient who is on magnesium sulfate has a higher risk of postpartum hemorrhage. And all of these are because that it works as a tocolytic. So now in this scenario, we can use that to our advantage. And giving magnesium sulfate has those tocolytic properties that can help potentially slow down contractions and slow down labor. It is not going to keep her from having a baby if she's in preterm labor. But if we can slow it down, it can buy us some time. So think about why I might want to buy time. The big answer to this is betamethasone. if my patient is in preterm labor and I think she's going to deliver, giving betamethasone is going to help promote lung maturity. And so we give this in 2 separate doses to mom 24 hours apart. So she would get a dose, and then 24 hours later, she would get another dose. And then 24 hours after that is when it is considered the best effect. So if we can keep her pregnant, the longer we can keep her pregnant, the more time we have to try to help mature the baby's lungs with betamethasone. Okay. So that's going to be true even for using nifedipine or anything. It's terbutaline. Nothing is definitely going to keep her from delivering, but it's about buying time. The other thing magnesium sulfate can do for us is called neuroprotection. And so if your patient is less than 32 weeks gestation, the little teeny tiny vessels in the baby's brain are very fragile. And being born before 32 weeks has an increased risk of cerebral palsy and brain bleeds. If we give mom magnesium sulfate, crosses the placenta to the baby, and it helps minimize that for the baby. And so that is the neuroprotective property of giving magnesium sulfate. So that's another reason why we might give it to our preterm labor patient. Now, remembering everything that we learned about magnesium sulfate in relation to preeclampsia, that applies here. It still has a risk of toxicity. We still have to do all the same monitoring. So we need to watch the urine output, make sure it's more than 30 mLs per hour. We're assessing the reflexes. We're assessing respiratory status. We're assessing level of consciousness. All of those things that we considered for preeclampsia on magnesium sulfate, we're still considering it here as well. Okay. So those are going to be kind of the things that we're looking at. We can also do activity restrictions. So during this time, we're putting her on bed rest. And then if it turns out that she's not continuing to dilate her cervix and she ends up being able to come off of her medications and go home, sometimes they still want to minimize the activity, put them on pelvic rest, things like that. Premature rupture of membranes. So this has to do with the water breaking before labor starts. So this is not premature like she's preterm. This is the water broke too soon, like in relation to the labor process. And so if this happens, we have some increased risks, because the longer the water is broken, the more that we increase our risk of infection. And that's the biggest concern we have. There's some other concerns that go along with the premature rupture of membranes, but typically infections are our biggest concern. We can also increase our risk of cord prolapse and some things like that we're going to look at later. If the water breaks and the baby is less than 37 weeks, then we are preterm premature rupture of membranes. So then we have 2 Ps. So if their water breaks early, since infection is the biggest risk, we are going to be monitoring for signs of infection. So what do you think might we see if she becomes infected? The concern would be, the things we would see is going to be fever, okay, greater than 100.4, tachycardia for mom, also tachycardia for baby. If mom develops a fever, baby often becomes tachycardic. And so maternal tachycardia, fetal tachycardia, and fever are the big 3 things. We can also see uterine tenderness. We can also see a foul smell to the amniotic fluid. The amniotic fluid could be purulent. So other signs of infection would be things like that. But our biggest ones are going to be fever, maternal tachycardia, and fetal tachycardia. All right. If the water breaks and she's less than 34 weeks, we might want her to stay pregnant. And so this was something that we've discussed before, that just because the water breaks doesn't mean she's in labor. Okay. And so if she's not in labor, if she's not having contractions and she's not changing her cervix and she's preterm, she's before 34 weeks, then maybe we try to keep her pregnant. So for this, we're really just kind of watching and assessing and waiting. So we can do antibiotics for sure. We're doing fetal assessments daily. So we're having her do her kick counts, and then we're also doing non-stress tests at least, usually what I see is at least once a shift, so twice a day. Okay. But remember, non-stress test is at 20 minutes of monitoring. We want normal baseline, moderate variability, at least 2 accelerations. Okay. And then monitoring for fever, tachycardia, signs of infection. We can be giving betamethasone. We can be, this would be a time that they could consider doing amniocentesis to look for the LS ratio. I will say honestly, we're not really doing that as much anymore because if you remember, the risk to that is preterm labor. And so we're looking at a benefit versus risk here. But this would be a time that we could. And then we might consider magnesium sulfate for her for neuroprotection for her baby. Okay. If at any point she's showing signs of infection, it's time to deliver, regardless of gestational age. So chorioamnionitis, this is the infection we're worried about. So if you remember when we looked at the video of the membranes that had the chorion and the amnion, this is where the infection is originating. And so it becomes an infection that includes the amniotic fluid and everything that's in that area. For baby, this can cause problems with the baby becoming sick and septic after delivery. For the mom, we have risk, I mean, infection. So really what we want to do is give antibiotics. All right. So typically we'll give Pitocin. I'm sorry. Oh my gosh. We also are going to give Pitocin if we want to get her delivered, but we're going to give like penicillin was what I was looking for, or ampicillin, one of the cillins, gentamicin, antibiotic to treat the infection. And we're going to assess for our signs of infection. So maternal fetal tachycardia, uterine tenderness, purulent discharge, like we said. And we're going to be moving towards delivery. For post-term pregnant patients, this is going to be beyond 42 weeks. All right, so remember 40 weeks is term, 42 weeks, any pregnancy that goes beyond 42 weeks has increasing risk of stillbirth. And so typically once they are over 41 weeks, we start trying to get them scheduled for an induction of labor because of these reasons. So for maternal risks, the longer she's pregnant, the baby's growing bigger, so we can have a macrosomic baby. If we have a macrosomic baby, that's going to increase her risk of C-section. So we talked about that in relation to diabetes. That applies for this as well. Okay. Increased risk of injury to her bottom during delivery, because if the baby's large, increased risk of birth injuries to baby if the baby's large, so shoulder dystocia. We can also have an increased risk of a labor dystocia. So a labor dystocia, we're going to talk about more in a minute. That is actually a dysfunctional labor that's not progressing well. And then mom can be tired. And so that can affect how her labor progresses. If you remember your P's, your 5 P's, her psychologic response can affect the way her labor progresses. So for our post-term patients, that can be a factor. Okay. Risks for baby for post-term. There's a few things that we're watching for here. So first of all, the baby again can be macrosomic. And so if our babies are macrosomic, then they have the potential to have a more difficult time fitting through the pelvis and increased risk for birth injuries. Okay. The other things that can happen when they're post-term. One thing is, remember that the placenta is not designed to be a forever organ. And so the placenta can start, the functionality starts to decrease. So we can start to see late decelerations on our tracings because we can be getting some uteroplacental insufficiency because the placenta is old. We can have what's called oligohydramnios. So this is when our amniotic fluid level is low. If our amniotic fluid level is low, then we have less cushion for the umbilical cord. If I have less cushion for the umbilical cord, now I have potentially compression on the cord. So what might we see for that? Variable decelerations. So our post-term babies can have late decelerations because of an old placenta, variable decelerations because decreased amniotic fluid. And then they also have, babies have a tendency as they get past their due date to have an increase in releasing meconium. Meconium is like the sticky, gooey, blackish, tarry stuff that comes out and for their first poops. And if they poop in utero and the meconium mixes with the amniotic fluid, babies can breathe that in and get that into their lungs, and then it can cause what they call meconium aspiration syndrome, which is a pneumonia. So those babies can have respiratory distress and problems there. So those are our risks for post-term. For dysfunctional labor, our dysfunctional labor is going to be an abnormal labor progression. So someone who went into labor and got to a certain point and is not progressing well. We expect a cervix to change a centimeter every 1 to 2 hours, depending on if it's her first baby or if she's had babies before. And so sometimes if we have like a cervix that's maybe 6 centimeters dilated, and 4 hours later, it's still 6 centimeters dilated. Well, why? Why are we not making progress? And this is where our 5 Ps really come in. Okay, passenger. What position's our baby in? Is our baby macrosomic and not fitting? Things like that. Power. Right? So we're thinking about, our contractions strong enough? Do we need to make them stronger? We can quantify that power with that intrauterine pressure catheter, IUPC. Okay. Our passageway, is it an issue where the baby's not going to fit through the pelvis? All right. Or is the cervix swollen? Things that affects the passageway. And then we're thinking about mom's position. Again, all those things we talked about before, like using upright positioning versus sideline positioning and different things to get your baby in a good position, and her psychologic response and how she's handling the stress and all those things. So all of our P's play a role in how our labor is progressing. And then we have a precipitous labor. This is the opposite of our dysfunctional labor, labor dystocia, because precipitous labors are fast and done. Okay, it's 3 hours or less from onset of labor to birth of the baby, and it's super crazy intense. The uterus is contracting hard and strong, and we probably have uterine tachysystole, where not tachy is fast, systole is contraction, right? So we've got it's squeezing like crazy. It can be holding on for longer contractions, and all of these things affect that uteroplacental blood flow. And so we can cause hypoxia to the baby when this is happening. Okay. And so then the other concern is when the baby comes down and out so fast, we can have trauma to the baby's head because it's so quick. And then it's going to have a lot more potential trauma to mom. So her uterus can rupture, like the muscle can actually rupture completely. Lots of times we see lacerations, so tearing, hematomas. She's going to have an increased risk of postpartum hemorrhage because now that uterus is tired and it doesn't really want to contract anymore. So there's a lot of things that go along with this. This is the type of thing when we said with women that are using cocaine that increases the risk of a placental abruption, and that it can also cause a precipitous labor. Okay, and so sometimes I see cocaine use, precipitous labor, placental abruption, they all are a package deal, but sometimes you can have a precipitous labor with cocaine use without having placental abruption, so it just depends. So when we think about obesity, remember that this is when the BMI is greater than 30, and we've talked already about the type of things that it can contribute to. So like preeclampsia, increased risk for preeclampsia, increased risk of diabetes, and also hypertension. All right. So your patients that are obese have a higher likelihood of having these other conditions as well, and having higher prevalence of developing some of the gestational conditions that we've discussed before. They also have an increased risk of hemorrhaging after delivery. They have an increased risk of needing a cesarean delivery. And a cesarean delivery has its own challenges when they're obese, because if they have a pannus where the abdomen drapes down, the place that we want to do a C-section is right here, kind of at the underwear line. And we call that low transverse. And sometimes if we do a C-section right there, then it's hard to keep the wound clean and dry. Okay. So next topic is aversion. This is going to be a way to take a baby who is breech or anything other than head down and make them head down. All right, so we do this externally on the abdomen. And in order to do it, we're going to first do a non-stress test to make sure that the baby looks okay. They'll do an ultrasound. They'll look and see where's baby, where's the placenta, and then we usually give a tocolytic to relax the uterus. Any thoughts on what tocolytic we might use for this? Typically, we're going to use terbutaline. Remember, terbutaline, though, can cause tachycardia, so we're going to monitor vital signs. And then the provider will manipulate from the outside of the belly, manipulate the baby, and turn the baby. This is typically very painful for the mom. This is completely elective. All right. She chooses to have this done because this is going to be her best chance of having a vaginal birth, because that most of the time cesareans are done for breech presentation. All right. So at any point, a mom can say, actually, this sucks. I would like to stop. And that's okay. But think about what could go wrong here. So we're worried about, if the biggest thing we're worried about is potentially causing a placental abruption. Okay. We do worry about where the cord is, and we do worry about some of these other things, but the thing we're the most worried about is disrupting the placenta. And so after this is done, they will monitor the baby and see if everything looks okay. So we monitor for at least 4 hours. And so think about what we might see on our fetal heart tracing if there is a placental abruption. So we might see late decelerations. Okay, oftentimes with an abruption, like we have said in previous weeks, that we see late decelerations on the monitor, maybe even before we see other symptoms. But think about our other placental abruption symptoms. Maybe bleeding, maybe painful, rigid, board-like abdomen. Okay. So for an induction of labor, this is where we are going to try to make the body go into labor before it starts on its own. And so there's a lot of reasons to do this, like she's preeclamptic, like she's past her due date, things like that, okay? Like some of the other things we talked about, risk factors like IHP, trying to think. Anyway, so let's think about when we would not do an induction. I would not do an induction for if she has a previa, right? Because she should have a C-section. I would not do an induction if she was breech, because she should have a C-section, right? There's a lot of different things. Like if she should not deliver vaginally, she shouldn't have an induction of labor. So let's think about why we would do an induction. Okay, medical conditions like we just talked about, preeclampsia, being post dates, past their due date. Another time we'll do them completely electively. Mom would like to be induced. All right. If we're doing it electively, then we are going to wait until she's at least 39 weeks. And to do an induction, the first thing we want to know is, what is the cervical inducibility? What are the chances I can get her into labor? And so they determine this using what's called a Bishop score. So they feel the cervix and they see, is it firm or is it soft? What position is it in? How thin is it? Where's the baby in the pelvis? Like what station? They look at all of these different things and they give it a score. And a Bishop score that's low means the cervix is not favorable. A Bishop score that's high means that it is favorable. And so greater than a score of 8 is good, but scores that are like 4 and 3 and stuff like that, we need to help the cervix out. Okay. So when we're thinking about how we're going to help ripen a cervix or increase our chances of inducibility, we're going to think about prostaglandins. And prostaglandins' job is to soften and thin the cervix, because if I give her oxytocin or Pitocin, okay, these are both the same thing, and I tend to use the terms pretty interchangeably. If we give her oxytocin or Pitocin, it's going to make her uterus contract. But if the cervix is closed and thick, then I'm just pushing on a closed door. All right. If we soften this up and make it squishy and open it a little bit, and then we give her contractions, we have a much better chance of it opening and dilating. So that's what our prostaglandins are going to do for this. So things we'll use for to be prostaglandins for an induction of labor. Cytotec. So think about Cytotec. We used Cytotec in high doses for something else. So dig in your brain and think about what we used Cytotec for. In high doses, we were using Cytotec for postpartum hemorrhage. Okay, that was one of our postpartum hemorrhage medicines. In tiny, because it helps the uterus contract. In tiny, tiny doses, it helps soften the cervix. Okay, so we can use Cytotec to induce labor. All right, Cervidil and prostaglandin gel are other prostaglandins we can use, and so they're all going to be for the same purpose. They're just all used a little bit differently. Okay, we can also use mechanical dilators, and this is going to have the advantage of not only helping the body release its own prostaglandins, but also putting pressure on the cervix to help it to open. And so in the picture here, this is a cervical ripening balloon. So this starts out a tube like a Foley catheter that they put through a cervix that really only has to be open a centimeter for them to get through it. And then they blow up the balloons. And the balloons then put pressure on the cervix. And as the balloon works its way through the cervix, it's mechanically dilating it. And that usually we leave those in for about 12 hours. Okay. Another thing we can do to help get labor going, intercourse. Semen is a prostaglandin, so we could encourage her to have intercourse at home. Nipple stimulation helps the body release its own oxytocin. Okay, so if we remember, oxytocin helps milk let down in the postpartum period. And it's going to, if she stimulates her nipples in pregnancy, then it causes her body to also release oxytocin. And actually that happens with intercourse too. If she has an orgasm, her body releases oxytocin. Walking can help because it can kind of get the baby in a good position to come down more in the pelvis. And then AROM. So an amniotomy or an artificial rupture of membranes can help a labor progress. So if we break the water, think about what risks might be associated with that. Chorioamnionitis. Also cord prolapse that I'm going to show you in a minute. Okay, so these are all things we're going to consider for an induction of labor. So oxytocin or Pitocin. This is a hormone that is produced in the body. The posterior pituitary gland makes it. It stimulates contractions and it aids in milk letdown. So if your patient is delivered and latching her baby, she's getting cramping as the uterus contracts. Right now in pregnancy, this is where we just talked about nipple stimulation can help with that. Okay. We use a synthetic form of oxytocin to help induce labor or to augment labor, to keep a labor that maybe like we have a dysfunctional labor pattern. We can give oxytocin to try to make those contractions stronger and closer together to keep the labor moving forward. This medication can be very dangerous. If we overstimulate her uterus, we can have tachysystole, uterine rupture, and if we're doing that, then we're not perfusing our baby well, right? We're not giving our baby good oxygenation. So if we don't use this properly, we can cause all sorts of problems. And it's also why we have to dose it very carefully. So all of the math practice you do surrounding oxytocin is because that this is dosed in milliunits per minute. Okay. So we give teeny tiny doses and turn it up a teeny tiny bit at a time to get this desired effect without totally making that uterus freak out. Okay. An augmentation of labor is going to take a labor that's already started and it's going to give it a little push. So if we've got hypotonic uterine contractions, if they're not very strong, if we are not making labor progress, she's been 6 centimeters for 5 hours, labor is not progressing at a satisfactory rate, this is something we can try. So if we go back here to our dysfunctional labor, this is considering the power part, right? If I'm concerned that I have a power issue, that's where we could put in an IUPC and see how strong the contractions are. And if they're not very strong, if our MVUs are low, then we can use some Pitocin and augment the labor. Okay. Breaking the water is another tool we can use to augment labor. So maybe she is having contractions, but she's not really making cervical change anymore. Sometimes breaking the water can be something that can help. But now we're thinking about risk for infection, monitoring her vital signs, and all those things if we break the water. All right, so forceps assisted birth. So this is going to be a patient who is now second stage. So think about what second stage is, where we're at. We are fully dilated and we are pushing, right? If we have a prolonged second stage, she's been pushing for 3 hours, she's exhausted, the baby's pretty low, we think we can hold on to the baby from below and pull, that might be better for her than a C-section. Okay, this is also something we might consider if we're close to delivery, but we're having like big decelerations and concerning fetal heart tracings. Okay, so let's think about the risks that go with a forceps delivery. What happens with forceps is they're going to put the forceps on either side of the baby's head. And then when mom pushes, they're going to pull. Okay. Important for the nurse to empty the bladder before this. Okay. So there's one less thing that's in the way. All right. And what we worry about for mom is lacerations to her bottom, hematomas. She could have bladder damage. Okay. Which could cause urinary retention later. For baby, we worry about bruising and abrasions on the face. There's a little bit of a risk of a baby having a hematoma in their head. Overall, though, forceps deliveries are pretty safe. However, not a lot of doctors do them anymore. All right, so your doctors who have been doing it for a long time are very well trained on forceps. I have known amazing forceps doctors. I'm like, yes, this guy's here. He's going to pull that baby right out. It's going to be great. If they're not trained on them, it's not good. I've also was with a doctor that wasn't good at it, and it was not a good idea. So definitely can be a very safe way to deliver a baby. More often, if we're assisting from below, we're using a vacuum. And with a vacuum, they put a little suction on the baby's head. So we prefer if it's the vertex part right here. Okay, but oftentimes if we have a mom that's been pushing for a long time, her baby might be OP, or like in picture A, or their head might be a little bit, not coming totally straight, or who knows. So, but we're going to try to get it as close to vertex as possible. This is also something the doctor's doing, not the nurse, okay? And they're going to put pressure on the vacuum, and they're going to pull as mom pushes. All right. So again, we're going to empty the bladder. I think I have a picture. I don't. They're going to pull while she pushes. We're going to empty the bladder beforehand. And the things that we're going to be watching for after for mom is still lacerations and hematomas on her bottom. Baby's risk for this is a little bit different. Okay, so a vacuum delivery can just increase the caput. And caput is not a concern. Caput is just like a normal fluid in the tissue. And the way that you know that it's caput is because that it crosses the suture lines. So when we think about the head, we've talked about before how the bones aren't fused. So if you palpated caput, you would feel it over more than one suture line. Okay. And so that can happen pretty commonly with a vacuum. The thing we worry about is a cephalohematoma. And a cephalohematoma doesn't cross the suture line. So if the suture line is here, my hematoma is off to the side, and then it stops at the suture line. And this is, we're talking about a hematoma, heme, it's blood. It's a pocket of blood in the baby's head. So later, when we talk more about newborn, we'll look at this more closely, but the baby's body is going to have to break down that blood. And so that baby is going to have an increased risk of hyperbilirubinemia and jaundice as well. Okay. For cesarean births, what we're thinking about for this, there's a few things a few considerations. So who might need a cesarean? It might be something that is just scheduled and planned. Maybe she has a placenta previa. Maybe her baby's breech. Okay. It could be scheduled and planned because she had a C-section last time. And so guys, if she has had a C-section before, she will definitely have the option of having a repeat C-section, because that once there is a scar on the uterus, it increases the risk of the uterus rupturing in a future delivery. Right? And uterine rupture on a future delivery is low. It's like 1%, but it's catastrophic if it happens. So some women choose to just have repeat C-sections because they had a C-section before. So that would also be scheduled. Okay. Some women have elective C-sections. Maybe they have a significant sexual abuse history. There's a lot of different reasons why women choose to have it. Okay. And then we have our unplanned C-sections. And on night shift, that's what they all are, is your unplanned ones. Okay. We didn't plan to do it. Now we have to do it. So if you have a patient that comes in bleeding and turns out she has a previa, that would have been a nice scheduled C-section. Now it's going to be an emergency. If you have a patient that has been pushing for 4 hours and we're not getting the baby to come through the pelvis, that's an unplanned C-section. if you have a baby that has non-reassuring fetal status and we've done all of our interventions, we turned off Pitocin, we've given IV fluid boluses, we've changed her position a bazillion times, we've given terbutaline to slow her contractions down, we've given oxygen, we've done all the things, and we are not getting our baby to look better, that might be an unplanned C-section. Okay. So it just depends. Ideally, the incision site should be low transverse. So like I said, when we talked about it with our obese patient, we want to do it down here, right at the bikini line. All right, and so it'll go across this bottom part here. And if they do the incision through the uterus that way, that uterus is going to heal really well. That'll be the mom that could choose to try to have a vaginal birth on a future pregnancy if she wanted to. If she has an up and down vertical incision, then she should not labor, and she should not have try to have a vaginal birth ever. So that plays a role too. Risk factors with the cesarean is going to be it's related to having surgery, right? So mom has an increased risk of injury to organs, increased risk of infection. And so for this mom, we are going to give antibiotics prophylactically, all right, because we're opening her uterus. And so she has a higher prevalence, a higher risk of endometritis, and so and wound infections. So she'll get antibiotics beforehand. We usually give moms also an antacid, because if she's having a C-section, she's laying on her back with just a little tiny tilt to prevent vena cava compression. And if she gets nauseous and starts to vomit, she's got an increased risk of aspirating. So we're going to try to neutralize the stomach acid using an antacid, like Pepcid. All right, depending on the location, sometimes they give them Zofran to try to minimize the vomiting and different things like that. All right, risks to baby. We could accidentally nick the baby and cut the face or the presenting part. Rare, super rare. Happens though, if it happens, it's typically because it's an emergency C-section and they're working very diligently and quickly to get the baby out. Babies that are delivered by cesarean have an increased risk of having some respiratory difficulties because they're not getting that squeeze on their chest coming through the birth canal. Their body still has potentially has a lot of amniotic fluid in the alveoli. So sometimes these babies take some more time to transition through that. Okay. For a patient with a C-section, their anesthesia is going to be dependent upon the situation. If she comes in for her scheduled C-section, she's going to get a spinal. If she's been pushing for 4 hours, she has an epidural that they can dose, hopefully. And if she is hemorrhaging with her placenta previa, she's going to have general. So those are some examples. Okay. Considerations. Before the surgery, we want to check her blood type and do type and screen in case we have any bleeding issues. We want to know when she last ate, okay, because they usually keep them NPO after midnight. We're going to want to administer medications as ordered, IV access, those things. Oftentimes the labor nurse is also the circulator in the OR. And so that's mostly just like getting supplies and doing counts and things like that. And then right after the surgery, we are not only doing our normal postpartum assessments, so checking the fundus, checking the bleeding and those things, but we're also watching the urine output, watching the vital signs, and assessing pain and things like that. Okay. Further along the line in postpartum, we might have them, if they had general anesthesia, we'll probably have them use like an incentive spirometer to help with their breathing and some different things. So if a patient has a C-section, I told you she has a 1% risk of uterine rupture if she tries to deliver vaginally next time. So that's, if they try to deliver vaginally next time, that's called the trial of labor. Let's try to labor and see how it goes. If she had her C-section before because that, like fetal distress, she could very easily have a really successful delivery vaginally the next time. If she had a C-section because of a labor dystocia where she didn't get to 10 centimeters, or she did, but she pushed for 4 hours, there might be a passageway issue that contributed to that. So she can still try, but she might not be as successful. So we just would watch. If we're doing a trial of labor, we need to have a whole team available in case it doesn't go well. So if a patient wants to try to deliver vaginally after they've had a C-section before, they have to deliver at a hospital that meets certain criteria. And so not all hospitals will allow women to do trial of labor, because they have to have anesthesia in-house. They have to have surgeons in-house. They have to have all these things right there that in an emergency can go and get this baby out right away. Because if the uterus ruptures, that is very bad, okay, for both mom and baby. If she succeeds, if she has a vaginal birth, after that has happened, now she's a VBAC. She had a vaginal birth after cesarean. So now we're going to start looking at obstetric emergencies. All right, meconium stained fluid. We mentioned this today. We talked about meconium aspiration syndrome in relation to our post-term baby. Okay, so what happens with this, and there's other reasons why you can have this. So it's the baby passed stool before they're born. This is often because the babies become hypoxic in utero. And if this happens where they have passed meconium, then the baby's at risk for respiratory issues after birth if they aspirate the meconium. Shoulder dystocia. So shoulder dystocia is a true obstetric emergency. Okay, what happens with this is the head has come out and the shoulder gets hooked up on the pubic arch or on the pubic bone. Right, and so they what we might see is what they call turtle sign, where the head is out and we've got momentum happening, and then all of a sudden the head sinks back in. So the head delivers, we've got momentum, and then it goes and it sinks back in against the mom's perineum. This can be caused by like abnormalities in our passageway. Right, so if you have a mom, a sister, something like that that has shoulder dystocia, that's something to be mindful of. It could be because the baby's macrosomic. So we have our postdates have an increased risk. Our poorly controlled diabetics have an increased risk. Anything that grows a baby big. Okay. Sometimes you have no idea, you don't even see it coming. You have no idea. Okay. So what happens that we're really concerned about is now the baby's body's in the birth canal, the head is out, we're not getting good blood flow through the umbilical cord anymore. So we're essentially asking the baby to hold their breath. We're not oxygenating our baby well. And now the baby's stuck in this position and we can't easily get it out. And so you got to think that time is oxygen, and how we are perfusing our baby is compromised, and we have to get this baby out quickly. Okay, so things we're going to try. The first thing we're going to try is called a McRoberts maneuver. McRoberts maneuver is going to we're going to push her knees back towards her ears. Okay, this is not the knee chest position because I need to use that for something else later. And so even though this does look like her knees are on her chest, this is not knee chest. Okay, this is McRoberts. So we're going to push her knees this way, and you can see in the picture how if it angles her pelvis this way, it can change where the arch is and change where the pubic bone is, and that might be enough to release the shoulder. Okay, so the very first thing, if I'm watching, I'm the primary nurse, and I'm right there, and the head comes out, and I see that turtle sign, I start lowering the head of her bed and pushing her feet back right away. See if we can resolve the problem. Okay, so that's McRoberts. The next thing we're going to consider is typically, and your provider, whoever is the delivering person, will call out what, hopefully they're going to communicate well with you and call out what they need. Typically, the next thing we'll try is suprapubic pressure. Suprapubic pressure looks like this, but it is not going to be the delivering provider that's doing it. Somebody is going to put downward, very strong downward pressure on the pubis. All right. And so the idea for this is to force that shoulder underneath the bone. All right. So if we do this, we can risk fracturing the humerus or the clavicle on the baby. And I would much rather a broken bone on a baby than a dead baby. Okay, so we are going to do it hard and strong. So in practice, if I do this, I actually climb up on the frame of the bed. And then with the closed fist, I put my weight, and I put my weight down into her. Okay, because we need the baby to go under the bone. Okay, and I don't care if I break a bone, and sometimes you feel it and that really sucks. But I got to do it. I got to get the baby out. So we can fracture the clavicle, we can fracture the humerus, but it's got to happen. So it looks kind of like if your baby's head is out and this is mom, we're putting this constant pressure here. And so this is why our humerus or our clavicle can be affected. All right. But that is going to be better than the alternative. The other thing that can happen to baby with this is called a brachial plexus injury. And so if the baby's head is out and the delivering provider is doing a lot of traction trying to pull the shoulder and they're pulling on the head a lot, they can stretch these nerves through here and cause a brachial plexus injury. Okay, so those are the risks for baby, well, and then asphyxia. And the longer that it takes to get the baby out, the more compromised your baby can be. The longest shoulder dystocia I had was 2 hours, or oh my gosh, not 2 hours, 2 minutes and 40 seconds. And it is the longest 2 minutes and 40 seconds ever. Okay. And so after the baby's born, for this, we're assessing for signs of a fracture. So this arm, if we broke a bone, then this arm tends to, they'll favor it, and so they can still move it a little bit, but it's like not equal. If we have a brachial plexus injury, then this arm just doesn't move at all. So we're watching for injuries for baby. We're assessing, we can do cord gases to see if our baby was hypoxic. Risks for mom is going to be trauma to her vagina, her perineum, and her rectum, because they are really working to get this baby out. One of the other things they might try to do that the provider does is reach in and try to deliver the posterior arm in order to decrease the diameter this way. So there's a lot of different things that can cause trauma to mom in that regard. So that is our shoulder dystocia. Cord prolapse is our other true obstetric emergency. I guess unrelated to bleeding, because we've already talked about placenta previas and abruptions and how bad those can be as well. So cord prolapse, here's what's happening here, guys. So if the umbilical cord ever is in front of the presenting part down into the vagina, like C is a good example. I mean, these are all, this one has the cord next to the baby. This one, it's in front of the head a little bit. This one is in the vagina. This one's in the vagina. If the cord is ahead of the presenting part, we have a big problem. Okay. And if the cord is ahead of the presenting part, we need to have a C-section, and we need to do it quickly, because the baby's presenting part is going to put pressure on the cord. And so again, I want you to think about how long you can hold your breath. Okay. So things we're going to do for this, if we find that the cord is ahead of the presenting part, we are going to, whoever is the finder is the holder. What I mean by that is, if I check and I feel a cord, I'm not taking my hand out. With my fingers, I'm going to put pressure on the presenting part like this, and I'm going to try to hold the baby off the cord. And then I'm pulling my call light and I'm calling an emergency. Okay. Now, things we could do. If the cord is in the bed, so this has happened to me before, like it was like coiled in the bed. Terrifying. I don't want to put it back. Okay, because putting it back inside can cause more pressure on the cord. You could wrap it in like a sterile cloth. I mean, with sterile saline, you could wrap it. I'm not even messing with that right now because I have an OR across the hall. I just want to get this baby out, but we could do that. And we could give her oxygen, but if I'm not getting the oxygenated blood through the cord, that's not doing a lot of good. All right. I want to put mom in a position that lets gravity help me keep the baby off the cord. So I said a minute ago that I was going to use knee chest for something else. This is it. So you can see in this picture here, the mom has her chest on the bed and her knees on the bed and her butt up in the air, and that's going to help rock the baby back. Okay, so gravity can help me. We can also do this that is called a side lying or Sims position, where she is almost on her belly. And that is also going to help rock the baby back. We can do Trendelenburg, where we take the bed and we lower the head of the bed to let the gravity rock the baby back. And then we're holding the baby off the cord and we're quickly going for an emergency C-section. Okay. Things that can increase our risk of a cord prolapse is going to be if we have a baby that's not really, if the baby's not engaged in the pelvis and the water breaks, that's when you see it. Right. So it can be a breech baby, definitely a transverse baby. If the baby's laying long ways, then there's nothing engaged in the pelvis. So if the water breaks, we can see it. Once in a while, it happens where the provider does an AROM or an amniotomy and the head wasn't well engaged, and as the fluid comes out, it brings the cord with it. But it also can just happen where the water is broken, she's laboring, and we find this. When I had one, we were doing an amnio infusion. So that's where we put that IUPC in, but we can put fluid back in to try to help cushion the cord. And she was 8 centimeters. And I think that when she finished dilating, then just because we were putting fluid back in, it helped bring the cord out, but the cord was in the bed. All right, so there's a lot of different times and places we could see it. Thankfully, it's very rare, but if it happens, it's an emergency. It has to be a C-section. We have to do it quickly. And so all of our things are going to be towards getting to the OR and getting the baby out and keeping the baby off the cord. So knee chest, Trendelenburg, fingers in the vagina, holding the head, those things. And then the other obstetric emergency that is thankfully super rare, but also catastrophic. Oh, sorry, this is uterine rupture. This is also oop, I muted myself. This is uterine rupture. I was thinking of another catastrophic one we'll talk about in a minute. For uterine rupture, this is if something disrupts the muscle. Okay, so most often this is going to be your patient that had a C-section before or had a uterine surgery of some kind before and tries to have a trial of labor and the uterus ruptures. That's most often when you see it, but it can be you can see spontaneous uterine ruptures. Okay. You could, if this happens, depending on where the uterus separates, you could palpate the baby's fetal parts in the abdomen. It's very painful to the mom. The uterine rupture that I was a part of, she was in excruciating pain. Her vital signs were horrible. So was baby. And then we did emergency C-section, and then she hemorrhaged afterward as well. It was bad. Okay. So ways to prevent it are going to be if she has any, for example, I had taken care of a patient recently that had an ectopic pregnancy, but instead of it being in the fallopian tube, it was where the tube attaches to the uterus. And so when they did surgery on it, they had to take out a little tiny piece of the uterus right there so she could never labor. If she did labor, then she could rupture her uterus. So things like that. Also, if she's got an overdistended uterus, she's got a lot of babies inside there, anything that's causing it to really expand and stretch can increase the risk of uterine rupture. Um, things like cocaine, again, causing tachysystole can cause the uterus to rupture. This was the catastrophic one I thought we were going to talk about. Amniotic fluid embolism, thankfully, is super rare, but it is also catastrophic. So what happens with this is something causes some piece of fetal cells, hair, whatever, to cross from being in the amniotic fluid to being in the maternal circulation. And when this happens, the mom's body like shuts down. All right, so we have a multi-system response. So we have respiratory collapse, cardiovascular collapse, DIC, all of it. Okay. If this happens, it is going to be a huge emergency. You won't actually know for sure that it was an amniotic fluid embolism unless she died and they did an autopsy. But you will recognize all, like if she has a multi-system collapse, you pretty much know that's what's happening. And so we're going to do CPR to start. There's a lot of things that will happen, but the things we're thinking about for this is, again, we're going to start with, we talked about this last week with, she's got to be on her back to do compression. So somebody, if she's still pregnant, somebody's got to hold that baby off the vena cava. And we're doing compressions. And if we're not getting mom back after 4 minutes, we do what's called a perimortem cesarean. And that's the best chance to save them both. I think that is all. That is all. So lots of scary things that can happen in labor and delivery. Thankfully, most of them are rare, but we need to be very prepared. I hope you have a good day.